Good morning, everyone. So we'll be discussing about Marfan syndrome and connective tissue disorders. So connective tissue disorders may be present in various types of genetic diseases, which may involve short stature as well. But for the purpose of this topic discussion, I'll be limiting to only those connective tissue disorders which present with tall stature. So Marfan syndrome is an autosomal dominant disorder. We all know by it now. And it's a very interesting autosomal dominant disorder because it displays various features of dominant inheritance, that is variable expressivity, complete penetrance, and pleiotropy. So I'm sure we're all familiar with all these terms, right? We all know what pleiotropy is. Do we all know? Yes? Yes? We all know what pleiotropy is, right? We all know what penetrance is?
Yes.
We all know how different it is from expressivity?
Yes.
Yes? So how to remember penetrance and expressivity easily? So a simple way to remember is if you switch on the switch of the fan, so that is penetrance, on and off. And if you use the regulator, that is the expressivity. So that's an easy way to remember the difference between penetrance and expressivity, right? Right. So how does Marfan syndrome actually cause the disease? It's an autosomal dominant disorder. So it causes the manifestation in basically two ways. Haploinsufficiency, where the protein is not formed, and dominant negative. Dominant negative means the protein is formed, but it disturbs the function of the normal protein. Now, why this is important for us? Because FBN1 gene, which is causative for Marfan syndrome, contributes to the formation of fibrillin 1. So fibrillin 1 is a protein which is responsible for collagen formation. And if this protein is not formed, then there is an abnormality in the connective tissue disorder. FBN1 consists of 66 exons, and there can be various types of pathogenic variants in this particular gene, ranging from complete deletion of the gene to just a base pair differentiation to hypermethylation disorders as well. So certain nonsense frame shifts, splice site mutations, gene deletions may lead to haploinsufficiency. Missense and in-frame insertion deletions can lead to dominant negative. So the point to remember in this is that these dominant negative can have variable expressivity, but these haploinsufficient variants usually do not have a lot of variable expressivity. So the most common feature is tall stature. But as you know, in our country, we are obsessed with tall stature. No patient would come to a clinic that, tall stature is a problem, Ek uncha lamba kar, so patient will not come to you directly. So the patient will go with the other manifestation. And the most common manifestation, what these patients have is of the eye. They come with eye. Most of them have myopia. They may have a lens abnormality. Some may develop retinal degeneration, and for this, they may present to ophthalmology. The second most common type of presentation that they have is cardiac manifestation. They have palpitations while working out, and that is how they come to the notification of cardiologist. The third manifestation that they have is pneumothorax. That is very commonly seen, spontaneous pneumothorax in tall adults, and that is how they present to pulmonary department. So as you can see, and you can see the tall stature. And the second photo, if you look very clearly, he has some stria-like structures on the back, if you can appreciate that. So stria can be present in normal individuals as well because of weight loss and for other problems as well. But those strias are usually present on the lower back. In his case, the stria are present in the mid-back and on the upper arm. So this is the typical presentation of the stria of Marfan syndrome and how we differentiate from the stria from stria which is normal. And of course, his fingers which show arachnodactyly. The other features, thumb sign and the wrist sign, again, these are again because of the abnormal growth of your fingers. And we also have fancy names for this, which we will not go in detail with. Pectus carinatum excavatum, many of them, they have it. Why the reason? Because of overgrowth of ribs. This is the reason why they have pectus carinatum and excavatum. Tooth abnormalities, but they rarely present for this to your dentist. The most common again is the aorta. They have an enlarged aorta and the eye lens dislocation. So for diagnosis, not every tall stature is Marfan syndrome. So Ghent is a city in Belgium. There they all collected and they decided that there has to be criteria how we call a patient to be Ghent criteria. So initially, this particular criteria was all clinical, that is based upon all the clinical features and the family history. But because of molecular diagnosis, they also include the presence of molecular pathogenic variant. Now, this particular inclusion becomes very important because there may be patients who have mild tall stature, they do not have significant heart abnormalities, but they have a pathogenic FBN1 variant. I'll show you one particular case of that. So that is why recognition of the fact that every mutation is not pathogenic is important again in this case. Right. So there are various features we all must remember. We can all just look through it, and this is something which we see in all our patients who are referred to as for Marfan syndrome. Important to remember was, what was important to remember? Right. So the important point to remember in all cases of Down syndrome, Marfan syndrome that I have seen is this arm span criteria, which is clearly known that the arm span to height ratio is supposed to be more than 1.07. So remember, in many patients of Marfan syndrome, you may not find that magic figure. The reason being this data comes from European populations. As a country, we have not reported enough Marfan syndrome to come up with the clinical criteria of own. I have collected many patients of Marfan syndrome in my institute, but unfortunately, I could just find 20 patients who had a mutation known. But then many studies have been done, but they have not particularly considered this fact of identifying arm span ratio. So I had this particular patient. The patient is marked by this arrow. The proband is marked by the arrow. He has a family history of his brother dying at 16 years due to some valve anomaly. Similar death due to heart disease in his father and his paternal grandfather. And he has a sister as well, who's apparently asymptomatic, but she also complains of palpitation. This young man, 17 years old, came to us with 19 years old, came to us with palpitation, dolichostenomelia, arachnodactylia, all those features. And his rallye aortic root, look at this, plus 9.13 standard deviation, that is 56 millimeters. So the cutoff guidelines where they offer surgery for aortic root dilatation in Marfan's is roughly 5 centimeters. Now, this particular number is also important because thoracic aortic diseases may be due to other genes as well, and they have a different cutoff as has been reported in the literature. He did not have a lens dislocation, but he had inferior lens coloboma. Again, many Asian patients with Marfan syndrome are known to have inferior lens coloboma as opposed to lens dislocation. And again, this as a criteria is not present in Ghent. So again, this could not have been applied. We did an exome sequencing in his case on research basis, and we found a likely pathogenic variant. So we could again counsel his sister based upon that. And the sister is a 3-year-old child. Do you think the child should be evaluated right now for Marfan syndrome for any pathogenic variants? Yes. Why? Follow for? Yes. If you can see his family, people have died as early as 30 years of age with cardiac disease. So it's important that we evaluate the child, even though the child is not of a legal age to give permission for exome sequencing. We need to evaluate the child to put him on follow-up for echocardiography. So many features of Marfan syndrome, they do coincide with other features, and that is why it's important to rule out all these syndromes. And these syndromes can be very easily clinically recognized. If you look at, for example, if you just look at the skeletal features may also be seen in Ehlers-Danlos, Loeys-Dietz syndrome. So again, you know Loeys-Dietz syndrome, they'll present with facial dysmorphism. Homocystinuria, again, they will have lens dislocation, they have increased level of homocysteine. Sprinz-Goldberg will have intellectual disability. Congenital contractural arachnodactyly, they will have contractures in addition to the tall stature and arachnodactyly. So you can easily distinguish based upon the clinical features, what am I exactly looking at, and then go for targeted exome sequencing in this case, because one gene can harbor many types of mutation, and maybe sometimes exome sequencing may not give you all the answers. So I made a table because for this patient, and I compared all the clinical features so that I have a ready go through assistance with me. So every time I have a patient with tall stature, I can easily distinguish based upon the clinical features what particular phenotype is he or she presenting with. The last column you see, I've left blank HTAD, that stands for hereditary thoracic aortic diseases. So initially it was thought that thoracic aortic diseases are different from all these Marfan's, Meester-Loeys and all these syndromes, but recently, we have proved that Marfan's and all these disorders are nothing but a part of this huge genetic syndrome called HTAD. So HTAD may be isolated or it could be syndromic as seen in Marfan's and other disorders. So how does it form? This is just basically to show you where the media is there and what various genes are involved. The most important thing to see here out is this TGF-beta1 gene. So why is that important? Because fibrillin, if you see out here, FBN1 goes and binds with alpha beta receptors out here, and they're nothing but part of this TGF-BR2 because FBN1 further leads to TGF-beta1 signaling. And we use metoprolol and various beta blocker agents because we want to decrease that TGF-beta signaling, and that is how it is used in the treatment. Again, you can see there are many genes which are involved, and all of them leads to isolated hereditary thoracic aortic disease. For some genes, the cutoff for suggesting surgery is as low as 4 centimeters. So that is why the importance of identifying the gene. Non-isolated HTAD, only 30% you will find a diagnosis. The reason being we do not know all the genes about which lead to HTAD. So there are many genes, FBN1, 65 exons, many domains, all of them lead to different phenotype as seen. So there is a strong genotype-phenotype correlation which is seen in this particular FBN1, although more than 2,000 pathogenic variants have been reported in this gene, and all the variants span all over the genes. But we have noticed that mutation in certain parts of the genes, they lead to specific phenotypes. So mostly this gene is associated with tall stature, but variations in the last exon, that is 64, 65, 66, they lead to syndromes which actually have short stature. So very surprising, but yes, they do. Wheel Marchesini, geophilic dysplasia, and all these are known as one gene leading to multiple disorders. Allelic disorders. What is pleiotropy then? Yes, one gene leading to multiple effects is pleiotropy. One gene leading to multiple disorders is allelic disorders. Can you tell me another gene which you must have seen very frequently which leads to allelic disorders? HBB is correct. I heard HBB. Deafness is locus heterogeneity. HBB gene, not thalassemia, HBB. Because I'm talking about allelic disorders, so I'll be talking about the genes, right? So there are many genes which lead to pleiotropy. FGFR3 may lead to certain disorders, right? So there are certain genes which lead to higher incidence of ectopia lentis. There are certain mutations in certain exons may lead to phenotype, mild phenotype, certain will lead to severe phenotype. So management, again, we skip through this, and counseling, we have to tell them that this aortic root dilatation is progressive. It cannot be controlled. Blood pressure should be managed. Beta blockers should be titrated. And if needed, surgery should be offered to these patients, because it has been shown that offering surgery timely can prolong their life by as long as 25 years. So I'll show you the second case. I got this case from Dr. Deepti and Dr. Asina. He was a 1-year-old male. His growth parameters are normal. The parents came that because the child had flexion deformities in his hands and hands, toes, and thumbs, and he had lax joint. Along with that, we noticed the child has arachnodactyly. Echocardiography was normal. He had high act palate. His father was already on metoprolol. He had features of Marfan syndrome. And he had already got an exome study done, and he had found a likely pathogenic variant. On examination, we found out that he also had flexion contractures of toes and ankle varus. So Marfan syndrome in father may not have presented as early as his presented is in his son. So do you think a prenatal diagnosis should be offered for Marfan syndrome if a variant has been found? How many of you would offer? How many of you would not offer? So those who will offer, raise your hands. Nobody will offer. Ma'am will offer. Ma'am, what is the reason?
If there is a possibility that the child is without Marfan, why not?
So you have to see, how do people with Marfan normally live? They are perfectly fine, right? Only they require surveillance. They only require surveillance for heart diseases, right?
That can be quite bad.
That can be quite bad. But I'm telling you, with the help of surgery, they are living long. So that is again the patient's decision whether to undergo prenatal diagnosis or not. But you have to offer the prenatal diagnosis if a variant has been found. You have to tell them that the child may develop cardiac issues in the future. Tall stature may not be a problem, but certain times they may develop pneumothorax and associated features because of tall stature. So, but otherwise, prenatal diagnosis for this condition is not really warranted. Have there been any reports? You have noticed short femur and have done, counseled the patient regarding that. Have you ever counseled a patient for long femur or a fetus who had long fetal bones? Never? Never? Yes. So if the child has prenatal Marfans, how would the baby present? They will have heart disease. That is how they will present, right? They will have those heart involvement, and that is various cases of those prenatal Marfans, how they have been reported is through this heart disease only. Otherwise, hardly long bones have been a cause for diagnosis. Again, tell you, because we are obsessed with tall people, right? So yeah. So again, we did a targeted testing in this baby, and we found that the child has this particular variant inherited from the father. This case was interesting. I got a 15-year-old female, and she came with the complaints of palpitation, which increased with activity for the last 1 year. And she has history of tall. She was a tall girl, and she has history of tall stature on her mother's side, although her parents were of normal height. Along with that, she also complained of myopia for the last 2 years, but she also had primary amenorrhea, and she was 15 years and she had not developed any secondary sexual characteristics. So, primary amenorrhea with tall stature, any differential diagnosis from androgen insensitivity and so there is one gene called Perrault syndrome. There's one disease called Perrault syndrome. This leads to tall stature with primary amenorrhea, but they have deafness. They have deafness, right? Deafness is very predominant in them. But this girl did not have deafness. She only had palpitations, tall stature, myopia, but she had primary amenorrhea. So anthropometry, again, if you see her arm span height, it is 1.07, crossing the magical number. She is underweight. If you look at her mid-parental height, that is 162.5 centimeters. She is already, over that mid-parental. So she's clearly tall for her height, right? She had long thin faces, high arc palate, wrist sign positive, thumb sign positive, again, Tanner stage in stage 1. So again, and this patient came to us with this Marfan habitus and an exome report. And the exome report said that there is an in-frame deletion of involving exon 32 to 34 of FBN1 gene. Remember, FBN1 gene is something which has various type of mutations, and in-frame deletions have been reported. These in-frame deletions, they lead to dominant negative type of Marfan syndrome, where the normal protein is produced, but it interferes with the abnormal protein is produced, which interferes with the work of the already working protein, right? So, and that is why the reason they classified this variant as a variant of uncertain significance. So she was referred from a primary physician to tell them whether she had actually Marfan syndrome or not. So what we did a 2D echocardiography, which said that there is a bicuspid aortic valve, mild AR, trivial TR, ascending aorta diameter, they also gave us. But the cardiologist decided that we also need to do further investigation. They did a CT angio, which only showed that the aortic valve is tricuspid. There is no dilatation of the aorta, right? USG showed that she has hypoplastic uterus. So I think FSH and LH, I think it's not coming there. FSH and LH was raised. And if you look at the point number 6, ophthalmology review, no lens deformity. So despite having a VUS in the FBN1 gene, an in-frame deletion, which does lead to Marfan syndrome, she does not have any physical features of Marfan syndrome apart from having the clinical features of a Marfanoid habitus. So what do we do in the next case? Do you label this patient as Marfan syndrome, or do you not label this patient as a Marfan syndrome? I'm telling you, in-frame deletions are known in the FB1 gene. They also lead to diseases. Although in-frame deletions, whenever you see an in-frame deletion in your report, be very, very cautious, because it is the frame shift mutations which lead to diseases, not an in-frame deletion, right? But FBN1 gene does have reports due to in-frame deletion. So do you label this patient as Marfan syndrome, or do you not? Marfan spectrum, there is no such disorder. So we can do in parents, as ma'am is suggesting. But do you think parents will have this particular VUS? The parents are phenotypically normal. So what would you do in this next case? I mean, she is a girl with primary amenorrhea, tall stature, may come to a pediatrician, may then be referred to a gynecologist, and then may be referred to a geneticist later on. So you will look at that this is a deletion, and now I want to confirm whether this deletion actually exists or not, right? So how do you see a deletion? Ma'am is suggesting microarray, and ma'am is suggesting we'll look in gene review. All right. Ma'am is suggesting MLP, right? Any more? PCR, somebody suggesting, perfect. Any more? How else do you see a deletion? So these are the various ways that you have told, but there's also another way which has been discussed in few of the classes, which nobody's saying right now. Huh? Agros PCR, she has said. So, microsatellite, what will that tell you? I'm looking at a large deletion, ma'am. Exon 32, 33 exon deletion. Whole genome, yes, that can also be done. So we can do many things, but what did we do? So this is a deletion involving 3 exons. Roughly, this was, I think, 15 to 20 kb in size, as far as I remember. So I went to microarray. I opened that CHAS database, and I saw where this FB1N gene was located, right? So, and I looked at the various markers which are present there, that if I decide to offer microarray to this patient, will microarray be able to pick up this 3 exon deletion or not? I found that very few markers are there. So performing a microarray for this patient would have been pretty much useless. MLP again was not available for FBN1. We could not have done that. So the next option available to us was to go for whole genome sequencing, as ma'am has suggested, but that was not commercially available. That is only available on research basis. So the next thing which I could have done was PCR. Again, I'll have to, plus ma'am, you must remember before designing a PCR in this case is that exome sequencing is reporting a 3 exon deletion, but exome sequencing will not exactly tell you the boundaries of that deletion. So this deletion may be 10 exons long, maybe just 1 exon long. So designing PCR for me in this case would be very difficult. I'll have to design multiple PCRs to finally get to the exact deletion, right? An easier commercial test, which is easily available, although a little costly, was exon array. So what does exon array does? It's like a microarray. It's a combination of microarray and exome sequencing, and it will only look at the various exons. So we called up the patient and they decided to undergo the testing, and on exon array, there was no deletion in the FBN1 gene, right? So now do you call this patient Marfan?
No.
This is a case. No, I'm telling you, the otherwise uterus was hypoplastic, ovaries were present, FSH, LH were raised. It could be otherwise, but then again, we had to have a diagnosis for this young lady. So primarily to us, she is a case of connective tissue disorder because she has tall stature. She definitely has those features along with primary amenorrhea. That's a very strong handle for us. So now this patient is actually under the undiagnosed disease project. We want to know what the diagnosis in this case. I actually looked her through her entire exome data to look for all the genes involved in the ovary and the uterus formation, whether primary amenorrhea genes, whether there is any pathogenic mutation or not, but I could find none. So this patient is still undiagnosed. So what I want to convey through all these case series that Marfan syndrome may be as simple as easy to diagnose, but there are diagnostic limitations. And despite doing all the tests, we may sometimes not find a diagnosis. Ma'am, there was no deletion because exome sequencing cannot exactly call a deletion. Something as big as 3 exons, exome sequencing will never confidently call that deletion. 3 base pair, yes, it will call. Maybe even up to 30 base pairs, right? So what decides how much length of the DNA can exome sequencing call it to be true? That depends upon your read pair. If the read pair is 75 base pairs, so up to 75 base pairs, any deletion called might actually be correct. But 3 exon deletion, very, very difficult, right?
We should not rely on such.
We should never rely. If you get a large deletion in exome sequencing, you have to confirm it by secondary methods. Like MLPA, like microarray, if the enough markers are present, ML or exon array if you have nothing else to save you. So exon array is a good test, but costs roughly 25,000, I think, in most of the commercial labs, right? So we end with this.